Welcome to Bioethics in the Margins. We are a group of bioethicists from different institutions across the country. This podcast represents our views and those of our guests, but we do not speak for our universities or medical centers, nor for any formalized bioethics organizations. Our mission is to bring marginalized topics and voices into the bioethics discourse. This podcast is hosted by Dr. Amelia Barwise, Associate Professor of Medicine and Assistant Professor of Biomedical Ethics at the Mayo Clinic, and Dr. Kirk Johnson, Assistant Professor of Justice Studies and Medical Humanities at Montclair State University. Please enjoy this conversation.
Welcome to another episode of Bioethics in the Margins, and we're very excited to have Dr. Deepshikha Ashana here today, and her research focuses on understanding and addressing mechanisms that cause differences in serious illness care among underserved patients. She uses mixed methods to study epidemiologic trends in national health claims data and understand patient perspectives on serious illness care with a particular focus on modifiable clinician and health systems factors. She received her undergraduate medical and business degrees from the University of Pennsylvania before moving to LA to complete her internal medicine residency at the University of California, Los Angeles. She subsequently worked as a management consultant at McKinsey & Company, where she gained experience in health systems operations and change management. While completing a fellowship in pulmonary and critical care medicine at the University of Pennsylvania Health System, she received formal training in research methods through the Master of Science in Clinical Epidemiology program. And Dr. Ashana is currently an assistant professor of medicine in the Division of Pulmonary and Critical Care and looks after patients in the Duke University Hospital Medical Intensive Care Unit and at the Health Centre at South Point. So you're very welcome here today, and thank you so much for being here.
Thank you for having me.
So you've had a very interesting training journey. So can you tell us about what brought you to where you are today and what you're focused on?
Sure. So as you mentioned, I spend a majority of my time right now doing research on inequities in critical care medicine. And regarding what brought me to this point, I was born in India and I spent most of my childhood there. And so it's a culture that I love deeply, but at the same time, there are also many inequities that are much more obvious than in the United States. So, for example, gender inequities, even the way that girls had access to education in my own family, things like that were very evident to me from a very young age. And then there's also, a deep history of caste-based discrimination and colorism in India. And so I think those sorts of issues have always just been very motivating for me. It's something that I've paid a lot of attention to. And then as an immigrant to the United States, I think I had this, what I now know was a false notion that this was sort of the shining city upon the hill where those things would not be true. But I moved here with my family when I was around 10 years old, and we moved to Philadelphia, which you may know that the demographics of that city are that it's a majority-minority city, meaning that a majority of the population is from a racially or ethnically minoritized background. And so the same sorts of issues that I had been seeing in India were very much evident, in my schooling and even in my medical training in Philadelphia. And so that was really the motivation for me to study what I do now, is those formative experiences as a child and then even after moving to the United States.
That's a wonderful background, for the work that you do. And I hadn't realized that you had spent so much of your life in India before moving here. So what caused you then to focus on race and how it pertains to critical illness and communication, and specifically around decision making?
Yeah, I think for me, much of my research, or really all of my research, is really motivated by my clinical experiences. And so I did medical school and my fellowship in Philadelphia. And so, like I mentioned, just the demographic of the city meant that the patient population that I was treating was predominantly composed of Black patients. And so those sorts of disparities in how communication happens in the ICU, how it seemed to me, and this is corroborated by research as well, that there's a much higher prevalence of conflict about treatment decisions between Black patients and families and ICU clinicians. And so those were really the motivating factors that led me to do research to try and understand why that is the case, and hopefully in the future to develop interventions to mitigate those sorts of disparities.
Well, many congratulations on your article in JAMA Internal Medicine. I know that was published in December 2023, and that described your qualitative work looking at racial differences in shared decision-making about critical illness. So for our listeners who aren't clinicians, can you describe what shared decision-making is, first of all, and then we can get into the kind of informational and relational aspects of shared decision-making?
Sure. So shared decision-making, I suppose, to define it, may be helpful to sort of contrast it to a more paternalistic approach to medical decision-making. So, historically, and maybe even to some extent nowadays, physicians or clinicians really used to dictate what sorts of medical decisions were made, what sorts of treatments patients would receive. And over the last few decades, there's been a shift to more shared models of medical decision-making in which clinicians are not solely responsible for making decisions, but instead they are expected to collaborate with patients and their family members to make medical decisions. And really the main goal of this is that in clinical situations where we are making what we call highly preference-sensitive decisions, meaning that 10 individuals in the same situation would each make a different decision based on what their preferences are for their medical care. So when we're in those sorts of medical circumstances, it is the case that the patient's preferences are crucial in order to make the right decision. We have to know what the patient wants for their medical care in order to make the correct decision in that situation. And so that's really been the motivation for this shift towards shared decision-making, is that we need to incorporate patient and family preferences into the decisions that we're making. And I think that, this model of decision-making is important in many settings in medicine, but perhaps it's my bias as a critical care clinician. I would say that nowhere is it more important than in the ICU. We have more and more treatment options available now to extend life, but that often comes at the cost of a different quality of life. I won't say reduced quality of life, because that is a value judgment that only a patient can make, but a different quality of life. And so those sorts of trade-offs between living longer and living differently really require patient and family input.
Thank you, Dr. Ashana. Can you please go over some of the findings that was illustrated in the JAMA Internal Medicine article?
So I'll just describe the methods of what we did a little bit so listeners can understand how we came to these conclusions. So we have an incredible resource that was shared with me by one of my mentors here at Duke in the context of a clinical trial that he did a number of years ago. He was able to audio record conversations, so real-world conversations between ICU clinicians and family members of critically ill patients, because in a vast majority of cases, the patients themselves lack decisional capacity or sedated, unable to participate in these meetings. So we have a collection of about 150 of these, what we call family meetings between ICU clinicians and family members of critically ill patients. And the goal of our analysis really was to compare, to observe how communication was happening in cases where a Black family member was present, and compare that to cases in which a white family member was present. So we did that using thematic analysis, which is an inductive form of analysis where we sort of let the data guide us rather than having preconceived notions about what we will observe in the data. And we identified 4 main ways in which clinicians' communication behaviors differ between conversations with Black family members and white family members. And so just to go through what those were, 2 of them deal with more emotional or empathic aspects of communication. So the first thing that we observed was that when Black family members shared negative emotions, things like feeling frustrated about their loved one's illness or sadness about their loved one's illness, that clinicians seem to respond less often. And even when they did respond, they responded in a less personalized manner. The second thing that we observed was that, contrary to what we often hear discussed in the popular media about Black patients' low levels of trust in the healthcare system, we actually saw quite a lot of verbal demonstration, at least, of trust. So a lot of Black family members said things like, I trust you. I trust that you're going to do the right thing for my loved one. And in those instances, clinicians really did not acknowledge those sorts of sentiments. So those were the two main findings related to the more empathic aspects of communication, was about these fewer and less personalized responses to negative emotions. And then even when positive emotions like trust and gratitude were expressed, that clinicians seemed to miss opportunities to respond to those. And then there were two other themes related to what we categorized as sort of more epistemic aspects of communication. So dealing with the knowledge that's shared in these conversations and how clinicians respected or did not respect the knowledge that caregivers brought to the table. So the first theme within that was really about how clinicians disclosed medical information to families, and it was evident in our analysis that clinicians shared less detailed information about critically ill loved ones with Black family caregivers. And then the second piece of it was that when Black family members shared information about their loved ones, so for example, what they believed their preferences to be, clinicians were more likely to contest those preferences, to sort of invalidate preferences. So an example of this would be, if a Black family member said something like, I want to continue providing this form of life support, the clinician would ask, is that really wise? What are we trying to accomplish here? So those were really the four main themes: two dealing with more emotional aspects of communication, and two dealing with how knowledge is shared and respected within these conversations.
Interesting. So these particular examples that you just illustrated, are these examples of what you categorize as a racialized empathy gap? Are these examples of what you're trying to, of course, alleviate within the aspects of clinical care?
Certainly, I would say the first two themes, I think, are manifestations of the racialized empathy gap, and that is a concept that, has been described a long time before this work in fields like sociology and psychology. So just for listeners who may not be familiar with this term and where it came from, the racialized empathy gap, as the name sort of implies, is when individuals feel or demonstrate less empathy for racially and ethnically minoritized individuals. So there is a body of research where there have been a number of interesting experiments done where, individuals are exposed to images or videos of individuals with different skin tones undergoing painful procedures. So an example might be you see someone with a lighter skin tone having a needle pricked into their skin, and then someone with a darker skin tone having the same thing done to them. And in different ways, they're able to measure how much empathy the viewer feels. In some cases, even using techniques such as functional MRIs, where they're actually looking for neurologic correlates of empathy. And what's been found is that sort of, regardless of the race of the viewer, so even if the viewer themselves identifies as Black or white, across the board, the viewers feel less empathy when they see someone with a darker skin tone being pricked by that needle. So that's what the racialized empathy gap is, that when we see others in pain, we're less likely to feel empathy when it's someone who has a darker skin tone. And these sorts of things have also been measured in education settings. For example, there is a really interesting study that was done by an individual at a North Carolina university where they asked teachers of young school-age children to identify emotions in their students' faces. And they found that these teachers were much less accurate in detection of emotion, and then also the type of emotion that they detected in their students' faces. So both for students of color and female students, they were much less likely to detect negative emotions or to misattribute negative emotions. So to say that, this student is feeling angry when in fact they're not. So there's a lot of literature supporting this concept that our ability to detect emotions and respond to emotions is racialized.
Wow. Well, thank you for that insight. And to further go along with these different examples, I know that dynamics of cultural health capital comes into play, along with racialized empathy gap, and I believe you mentioned a couple of scenarios previously. For our audience, can you first of all explain what cultural health capital is for those that don't know or understand that particular terminology, and if you could give an example of that as well.
Sure, yeah, I'd be happy to do that. So, cultural health capital, again, is a concept that was defined, about 14 or 15 years ago now by Janet Shim. And what she proposed was that we come to health encounters with a toolkit of skills, knowledge about how we present ourselves in these encounters, how we should communicate in these encounters, how we can advocate for ourselves and others in these encounters, that help us to advance our goals in these clinical spaces. And so that's what cultural health capital is. So, for me as a physician, if I were to go into a doctor's visit, for example, I sort of know the lingo to use. I know how to dress, how to present my concerns, right? And so that is what cultural health capital is. And you don't have to be a physician to have it. There may be many different ways that people acquire cultural health capital. So that's sort of what the concept is, and we definitely observe that in our recordings as well. It seemed to be the case that in conversations with white families were more adept at using those sorts of skills, at advocating for themselves and their family members in conversations with clinicians, which, as I mentioned, there may be a variety of reasons for that, but as Amelia had mentioned in her introduction, I tend to focus more on what's the clinician's contribution in these sorts of instances. And so more concerningly, what we noticed was also that clinicians responded differently to cultural health capital when it was deployed by white families versus Black families. If a white family member uses prior knowledge of healthcare or personal connections with physicians who may be friends of the family, things like that, that sort of thing was received pretty positively by clinicians in the recordings that we had versus when those sorts of skills or resources were shared by Black family members, they seem to be perceived as almost, threatening to the clinician's expertise or recommendations. And so that's the piece that we focus on more in our themes in our paper, because that, I think, is more modifiable at the level of, researchers in the healthcare system.
Well, it's a fantastic paper, so congratulations. And then just before we, kind of move on to one of your other papers that we'd love to discuss, thinking about relational, informational aspects of shared decision-making. Relational, I presume, is more how you relate to people and communicate with them, whereas informational is how much you're sharing in terms of sort of nitty-gritty prognosis, diagnosis, treatment options, etc.
That's right. Yeah, that's right. And, going back to when I was speaking about those themes, the way two themes each sort of seemed to fit within each of those buckets, right? We had two findings that were more about emotion, which I think is about those relational aspects of shared decision-making, and then two themes that were really about knowledge and how that's shared, which is more about the informational aspect of shared decision-making. And there, again, is a lot of literature on this cognitive affective model of decision-making, which, for a long time, I think in economics and other sorts of similar fields, people thought for a long time about humans as very rational actors who made decisions based on logic and information. And now increasingly we're recognizing that our decisions are hugely influenced by emotions. And I think in the healthcare context, again, that's not true anywhere more than in the ICU. The decisions that family members are being asked to make are really complex, often dealing, potentially with the death or disability of their loved one. And it's just a time of tremendous stress for them. And so these decisions are hugely laden with emotions. And so that's sort of what we're referring to when we speak about these relational and informational aspects of shared decision-making, or the cognitive affective components of shared decision-making.
So you've also looked into conflict in the ICU and how that's perceived by families as well as, physicians. So can you talk to us a little bit about your findings there?
Sure. So using data from the same trial that I described earlier, from where we were able to access these audio recordings, we did a separate analysis in which we looked at cases which comprised the family member and the clinician of the same patient. So we were able to sort of pair family members and clinicians to each other, get their perspective on the same relationship, but from two different parties of that relationship. And they had been asked a question in the trial about whether they perceived conflict about treatment decisions in that relationship. And what we found is that there was virtually no agreement between families and clinicians about when conflict exists. So, families report that conflict is happening and clinicians are unaware of it, and vice versa. Clinicians report that conflict is happening and families are unaware of it, which, that in and of itself is sort of troubling, that someone might perceive something like conflict about the decisions that's going to be made and that the other party is not privy to that perception. And then the other thing that we observed is we looked at the characteristics of both family members and clinicians who are more or less likely to report conflict. And in both cases, we found that race was a major factor, meaning that clinicians were more likely to perceive conflict with Black families, and families were more likely to perceive conflict with I won't say Black clinicians specifically because the number was very small in the study, but with racially and ethnically minoritized clinicians of any type. And so, I think that again sort of speaks to this concept of the empathy gap, that we're sort of less accurate at detecting emotions in other people, that we're less accurate perhaps at sort of feeling the temperature of a relationship when the person that we're communicating with is sort of dissimilar. And I think many of your listeners will be familiar with this concept of outgroup bias. So I think when we identify somebody as sort of dissimilar to us or from a different social group as us, that is when these sorts of misperceptions about, or I won't say misperceptions because I'm sure that the perception of what's happening is real, but lack of shared perceptions are more likely to arise.
Interesting. And as a follow-up question, do you know or have any metrics or understand or have any knowledge of any metrics of what cause or different causes of this empathy gap within clinicians? Is it their training, in higher education? Could it be something connected to cultural capital as well? Can it be an array of different factors that contributes to the empathy gap?
Yeah, that's a good question. And, we don't know for sure what the cause is, but I would say that I think it's very unlikely to be related to the profession. I don't think this is something unique to clinicians or teachers. It's unlikely to be related to the type of training that people are receiving. I think, when we sort of think about different levels of racism, with structural racism sort of being, the most prevalent and influential, this is, I think, just a manifestation of the structure in which we all live, right? So that if society sends us these messages, these sort of dehumanizing messages in popular media and, through political discourse and things like that, then those sorts of messages from a very young age are sort of internalized, and these are simply how they manifest. So I often say this when I give talks about my work, and I want to say it here too, that, the goal of this work is never to villainize clinicians. It's not to say that there are bad clinicians and good clinicians. I do this work because I love my profession. I love medicine. I think that, we go into this field because we want to do our very best for patients. And so this is simply shedding light on an opportunity for us to sort of embrace that, yes, this is happening and how can we improve? So I think this is really, to answer your question, I think it's a manifestation of structural racism. I don't think it signals a failing of any individual clinician, but it does highlight an opportunity for us now that we know that this is happening, for us to develop interventions and strategies to ensure that it doesn't keep happening.
Yeah, absolutely. So unconsciously, from a very young age, we, of course, observe and see, and then we internalize that. And then, of course, when we internalize it, we, of course, act it out with many times without even knowing that we're doing that, right? Which is really interesting as well with our upbringing. So to follow up, I definitely want to go back to the previous article about trauma-informed care, which again, to ditto my colleague, Dr. Barwise, it was another great article that you produced. So for those that don't know, what is trauma-informed care, and how does trauma-informed care impact an ICU stay, for example? And are these particular experiences traumatic for most patients in your experience and in your research?
Yeah, that's a great question. So I might answer the second part first, which is yes, we know that critical illness and critical care are hugely traumatizing both for patients and families. So just as an example, the prevalence of PTSD, post-traumatic stress disorder, following critical illness is as high as 30% in patients and families, which is similar to, or maybe even slightly higher than, the rate of PTSD in military veterans. So ICU care and critical illness is hugely traumatizing, yes. And then to return to your first question, what is trauma-informed care? So trauma-informed care basically is an approach to any sort of service delivery. It doesn't have to be in healthcare. It's an approach to any sort of service delivery that acknowledges that an individual's life experiences, especially their stressful or traumatic life experiences, influence how they perceive and react to future stressors, for example, critical illness, and that there are things that the service delivery organization can do to ensure that current stressor does not reactivate prior trauma or become an incident trauma in and of itself. So this approach to service delivery is most common in behavioral health settings and education, so in schools, for example. And there has been a move in the last couple of years to integrate this approach to healthcare as well, most commonly in pediatric settings, because there's much more of a recognition in pediatric care that trauma has a huge developmental effect on kids. It, literally rewires or reshapes the way that your brain is wired and reacts to future stressors. But I think there's also huge potential for a trauma-informed approach to critical care for adults as well, because of what I said previously, that we know that episode of critical illness triggers a very high incidence of PTSD following that episode of care.
Yeah, absolutely. Just a comment before my friend and colleague Dr. Barwise comes. I'm interested, not to say if you have any concrete results of this, but of course with PTSD and COVID-19, folks experiencing family members dying, especially 2020, 2021, where we're still trying to figure out what about the virus, and folks could even come in to see loved ones because everyone was quarantined, and of course that is a highly traumatic experience. I don't know if you have come across any type of research in regards to that. If you'd like to comment, if not, that's perfectly fine. But it definitely, I think, is connected to your previous comments about trauma-informed care, and of course, not just patients, but also PTSD for healthcare professionals as well that had to endure that really, really difficult moment in our society at that time.
Yeah, these are great questions. We haven't done any work personally on that, but there's an investigator, Nancy Kentish Barnes, who has a lot of work in this space, sort of examining the incidence of PTSD following critical illness during the COVID era. And there's also a lot of really interesting qualitative work about how COVID modified that experience. And there's one qualitative paper by that group in particular where they describe, exactly what you were talking about. So what does it feel like for a family member who was not allowed to go to the hospital and then their loved one died there? And they really describe that, almost as if it's a hallucination. It can't be real because they were not able to witness it. So it seems like their loved one was abducted or simply just disappeared because they were never, given time to sort of witness that dying process. And our normal ways of grieving were disrupted because we were not able to congregate, and all sorts of related factors. And so I think COVID had a huge impact on how patients and families experience critical illness. And then the flip side of that, you're totally right, is that there's a huge impact on healthcare workers as well. So there's a colleague at Duke, Jason Nuesma, who works at the Veterans Affairs Administration, and he did a great paper where he compared, it's not exactly PTSD, but a different concept of moral injury among healthcare workers and combat veterans. And again, he found very similar rates of moral injury between healthcare workers during the COVID pandemic and combat veterans. So just, sort of sit with that for a moment, that combat veterans who have been in war, and have, in many instances, probably killed people, they have similar rates of moral injury as healthcare workers who are delivering care during the COVID-19 pandemic. It's just an astounding finding. And for those of you who are not familiar with what moral injury means and how it's different from PTSD, moral injury basically refers to, when you do something and when you're compelled to do something that is sort of against your moral code or your principles. For example, how a combat veteran may feel at times. So yeah, there's a lot of research about how COVID has modified that experience of trauma related to critical illness for all parties involved.
Yeah, that's a really interesting point. So I'm wondering, what are your thoughts about implicit bias training then to address some of the things that you've noticed in the ICU? And also, maybe you can tell us more about what's next in your research program, any interventions you see that can help address some of these biases or sort of differences and disparities in decision-making that are sort of mediated through, poor clinician, I don't know if I'd describe it as behavior or communication.
Yeah, that's a great question, Amelia. And, I think there's an empirical question in there whether interpersonal racism can be mitigated when structural racism still exists. I don't know. That's something that we should study and figure out. It's an open question. I think we have equipoise about that. And then regarding what specific types of interventions might work, I think the way that implicit bias training is currently conceptualized and delivered, which, as I've typically experienced it, is, like a single day course, or maybe even an annual course, that's probably less likely to be beneficial, would be my hypothesis, just because any sort of behavior change we know requires, constant feedback and modification. So I think that the way that it's implemented right now, I would hypothesize, probably has limited benefit. And as far as I know, there really have not been any evaluations of implicit bias training, which is, of course, problematic since it's so widespread, especially in a lot of corporate cultures. So that's the answer to your question about implicit bias training. And then to talk a little bit about what might be next in our work, Dr. Liz Chuang and I actually have been talking a bit about, what are ways to mitigate bias in these clinical encounters. And I don't know yet. That is the next phase of the work, is to try and figure out what sorts of interventions might be effective here. There is limited literature from the psychology literature where, they've done small experiments with college students, those sorts of things. When we were in college, we got a few dollars to participate in. They've done small experiments of that sort of scale, looking at different things like perspective taking or counter stereotyping. And they have shown some promise in reducing biased communication or biased behaviors in different social interactions. So, perspective taking simply means if you take the perspective of someone who is dissimilar to you, or in other words, if there's a social interaction where outgroup bias may be at play, if you're able to take that other person's perspective, sort of humanize and personalize them so that they become in the in-group, then that has potential to reduce bias in that relationship. And then the other one that I mentioned, counter-stereotyping, basically means that, when we encounter someone who is dissimilar to us, often there's a stereotype of a person who we have encountered previously that we sort of anchor to, that sets our expectations for how this social interaction will go. And if we can instead, if that is a negative stereotype, if we can sort of reframe that to be a positive stereotype, then that has also been shown to be beneficial in reducing bias in social interactions. And I think this is sort of linked back to that point that we were talking about earlier about, media representation of racially and ethnically minoritized individuals. If that's sort of the dominant narrative that we see, then it's very likely that when we are interacting with people from those groups, that is the negative stereotype that is most salient in our mind. So it's sort of this, active process to reject that stereotype and instead think of a more positive experience. So those are types of things that we may try in the future, but stay tuned because I'm sure there will be lots and lots of failure before somebody figures this out. And I hope that, lots of people are trying to address this same problem because it's a big one that will require many brains to solve.
Absolutely. It's very, very challenging. Well, thank you for the examples. Any other things that you'd like to discuss or mention about your recent work or next steps?
I guess the only thing I wanted to clarify is we spoke a little bit about trauma-informed care and, again, just making that point about, I think it is most impactful to focus on how clinicians and health systems contribute to inequities in those encounters. So I just want to clarify that when we're talking about trauma-informed care, the focus there really is not about the individual who has experienced trauma. The goal is not to, of course, change their life experience because we can't do that, or even change the way that they interact with the healthcare system. But the goal really is to give clinicians and staff an understanding of what traumatic stress may look like in the clinical encounter and to give them tools to productively approach it. Because I think what happens currently is that, when people are experiencing a high amount of stress in clinical encounters, that often manifests as behaviors that are unexpected for the clinician or unwanted by the clinician. So things like, avoiding the situation. So avoidance is a really classic manifestation of traumatic stress, or hypervigilance. So sort of asking a lot of questions about the medical plan that may sort of be seen by clinicians as interfering. And so I think those sorts of clinician responses to traumatic stress symptoms can often be unproductive, or in the worst case, even inflammatory. They can sort of escalate the situation. And so when we're talking about traumatic or trauma-informed care, I just wanted to make that point that, the intervention is not for the patient, but it's really about training clinicians to reframe their responses to those symptoms.
Absolutely. Kirk?
No, I don't have any more questions. Thank you very much, Dr. Ashana, for your expertise and really making us look into this in a different lens than before. So highly appreciate your perspective and your wisdom in this topic.
Thank you so much for having me. It's been my pleasure.
Thank you for listening to another great conversation on bioethics in the margins. This podcast is hosted by Amelia Barwise and Kirk Johnson. Our producer is Elizabeth Chung. Our editor is Madeline Mahoney. Our theme music was written and produced by Pablo Cortes. We are grateful for the assistance of Wendy Jung, and Gargi Pandey is our creative director. Nicole Strand is our advisor, and Steven Sadecki is our senior advisor. Join us again next time.